Good Friday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement, in for Dr. Steve Stites, our Chief Medical Officer. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio, and it is Follow-Up Friday. Many of your questions this week have focused on the J&J and other vaccines and how they've made the news, and that's why we've invited Dr. Kevin Ault to join us. He's an OBGYN physician here and also sits on the CDC Advisory Committee for Immunization Practices, an independent group of experts who provide vaccination guidance to both the FDA and the CDC. They met this week, and he's here to share a bit with their findings with us. But first, as always, Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. How do we do overnight, Dana?
Yeah, I think we're still climbing up or inching up, and I think we are seeing overall in the nation numbers climbing, and in the Kansas City area, active new infections increasing as well. But here at the hospital, we have 14 acute infections, 3 in the ICU, but all 3 of those are on the ventilator, so critical illness at that point. 13 still in that recovery period, so total of 27. Still under that 30. We would like to get back to 20 total if we could. Hays has 4 patients, 3 in the active phase and 1 in that recovery phase. So.
And definitely the slow climb that you mentioned, Dana, is actually what we anticipated this week. We're pretty spot on with our forecast for the end of the week, which I always remind everyone we would rather be wrong. We would rather that forecast be high. But as far as our planning, this is sort of what we've been anticipating, and hopefully not necessarily foreshadowing specific continued worsening, right? Because we have nearly doubled on the acute numbers from 10 days ago to now that are in the hospital. That's not hospitalizations, of course, though that's census. And so we'll keep paying attention to that, but definitely not a feeling that we want this morning on a Friday. Before we get to reporter questions this morning, Dr. Ault, thanks for joining us.
Thank you.
I know that the advisory committee, the ACIP for short, met yesterday or this week? Wednesday, yeah, to consider the pause, the FDA pause of the J&J vaccine. Can you actually tell us a little bit about what the ACIP is, because it's not just for this vaccine or this problem, and also how long you've participated and sort of how you got to the point of participating on the panel?
So the ACIP is a group of 15 experts. We're appointed by the Secretary of Health and Human Services. I'm the second OBGYN in the group to be a member of the group. It's about 60 years old. It really started around the time we had a measles vaccine to make a recommendation about. We usually, in a year when there's not a global pandemic going on, we'd usually meet 3 times a year to talk about vaccine policy. We usually make the clinical recommendations about how vaccines are used. And so this year we've had 10 or 11 emergency meetings on top of our regularly scheduled meetings. And on Monday night, we got a text late at night about the pause that started on Tuesday. And then also in that text we got was inviting us to be in the Wednesday afternoon meeting for this specific topic about the safety signal with the J&J vaccine or Janssen vaccine.
And what exactly were committee members reviewing or looking for in the sense of data as it relates to this J&J pause?
So there are about a half a dozen safety systems in place to watch for vaccine safety, and they've been very active, of course, with the number of Americans that we're vaccinating every day about this. So in the VAERS system, which is a passive system, there were reported cases of a clinical diagnosis of thrombosis, so CVST, I think, is the acronym, and it's clots in the veins in the brain, along with thrombocytopenia or low platelets. So there were 5 cases and possibly a 6th, and a lot of them came up at the end of last week. So there have been about 7 million doses of the J&J vaccine that have been distributed. So we were able to detect, the system really worked. We were able to detect a possible safety signal using those systems. That was 1 in a million, basically, is what we were finding.
And you mentioned that the signal came from VAERS, the Vaccine Adverse Event Reporting System.
Yes.
It's a passive system. Explain what you mean by that.
Well, physicians like us, if we heard about an adverse event, would report that to VAERS. You could report if your relative or you were having an adverse event. Frequently, they're reported by the manufacturers of vaccines, so it's meant to be a very broad net as far as potential side effects and adverse events related to vaccines. We actually found the allergic reaction to the RNA vaccines in December through the same system. It's 1 in several hundred thousand, so it worked for that as well. So there are multiple other overlapping systems, and so as we go into our next meeting next Friday, I assume we'll get some data from those systems as well.
And one of the reasons I wanted to talk just a little bit about a passive system in VAERS before we talk a little bit more about the J&J vaccine is, you mentioned, right, physicians can report, family members can report, patients can report. So this is really casting a wide net to try to catch as many different potentials as possible and then really dig into them.
And when something as serious as this diagnosis is reported, the CDC starts calling people, calling physicians, calling family members, getting records, and that's going to be part of what we talk about next week on our follow-up meeting.
So, knowing that you're meeting next week and that you'll be digging into information from other systems, other safety systems, what did you learn this week about the J&J vaccine that you can share, and maybe a little bit about what you think is next, what the path looks like?
Well, as I said, there were 6 cases, approximately 1 in a million, and so we dissected those individual cases. They were all in women. I believe 18 to 48 was the age range. This particular diagnosis does skew towards younger women. And can we do the graphic that I can see in here? That might be helpful. So, and you can see the abbreviation cerebral venous. Cerebral venous sinus thrombosis, CVST. And so this skews towards younger women, so it wasn't surprising that younger women were affected. In the clinical trial, there was 1 male and 1 young woman that got it. The young woman happened to be in the placebo group, but the male received an active vaccine. I see this diagnosis every once in a while because it's elevated in pregnancy. It's, as you can see from our graphics, 10 to 12 per 100,000 deliveries. So an obstetrician's going to see this every once in a while. And you can see some of the other risk factors, again, that skew towards younger people. The question is whether the rate is higher in people that receive the vaccine or in the general population. And so that's really what we're going to talk about. So the denominator, is 7 million doses, but if you look at a smaller set, only women or only younger women, then we need to make a calculation about what the rate is, and there may be other cases that were missed, and so they're going through the database with a fine-tooth comb. One of the other systems that I mentioned is the VSD system, Vaccine Data Safety Link system, which has a control group, and so they have 150,000 people that have received the vaccine in that system and no cases of this. So it's, and I also asked during the meeting if anybody was nerdy enough to listen to the actual meeting. Johnson & Johnson has used this vaccine before for their Ebola vaccine and their RSV vaccine, so they have clinical experience. And in the Ebola trial, there were pregnant women and younger women involved in those trials. They didn't really see, cases in previous experience. So we're basically gathering data, I think, is the short answer to your question. So.
And I think it's interesting. If we look back at that graphic, you have several different things listed here. You have, first, the rate of cerebral venous sinus thrombosis in the general population, and it's 3 to 15 per 1 million, or maybe 18 to 50 in 6 million.
Right.
And we're seeing 6 in 6 million in the vaccinated population. It's very, very possible. Now, as you said, we may have missed some cases in the VAERS data, so we look in all the other.
Right.
But it's very possible that what we're seeing here is the normal rate.
So the thrombotic events that aren't this diagnosis, just plain old DVTs and pulmonary emboli, of course, those are serious diagnoses. I don't want to take them lightly, are equal between people that receive the vaccine and people that don't receive the vaccine, and they're more common. I should comment about Dr. O'Shea, who generously agreed to let me use his graphic today and yesterday. Yes. He's an infectious disease doctor at Emory, where I used to work, and we're using this with his permission. So.
Yes, it's an excellent graphic because it really does address lots of things, right? Yeah. The risk of this same complication in pregnancy or simply in those who take oral contraceptive pills is sort of addressed here. And while this is rare,
Right.
we know plenty of other circumstances where there's an increase, and maybe we're not even seeing an increase related to this vaccine.
And some of the other things like head trauma we don't have up there. And so, it's common enough that we, see it in pregnancy. I think the caveat, though, and this was in the health alert from the CDC that went out on Monday, some of these people have anti-heparin antibodies, and so that they gave some treatment guidelines. One of the things I mentioned at the meeting on Wednesday, our group is very widely represented. Other than the 15 voting members, we have about 60 liaison members, and that's actually how I got started, was representing the American College of OBGYN. But I don't think we have any ER physicians in the group, and so I was reassured that the health alert should be posted in our ER and ERs across the United States. I know I've sent it to lots of places because the symptoms of this can be rather vague. Headache is going to be the most prominent symptom, and lots of people go to the emergency room with headaches, and lots of people don't have this. So it's going to be hard to tease that out.
And I would just like people to, focus in on that second column right there of the number or the rate of cerebral venous thrombosis in people that get COVID-19. So it's quite high, 4.5 at a minimum of 100,000 cases. That's not even 1 million doses of vaccine. That's 100,000 cases of COVID.
So 45 to 200 per million, right, compared to the 3 to 15 per million in the general population. So COVID-19 puts you at risk of something like this. It's much, much greater than the risk we're seeing related to the vaccine, at least that we know of at the moment with these 6 cases that we understand. Where I think we always have to put that disclaimer. As we get into the other systems, we may find that there are more.
At this time,
We also went over AstraZeneca data, which they do not have an emergency use authorization yet in the United States, but they have a somewhat similar vector and have seen thrombotic events, and their safety data, mostly from Europe, looks a little more heterogeneous. It wasn't specifically this diagnosis, so again, it was kind of hard to know about the signal to noise ratio, similar to this graphic that you're seeing here. So, but I'm sure we'll revisit that when we talk next Friday.
All right. Well, we've sort of had a deep and wide-ranging conversation already about the J&J vaccine and events of this week. Are there any reporter questions on the line this morning?
Sure. Good morning, Cody Holyoke with Channel 9.
Morning, Cody.
Hi. I have a question for Dr. Ault and then a non-J&J question. I know that's going to blow your mind. But when we talk about J&J, Dr. Ault, what needs to happen for this committee to recommend the continuation of the rollout? What are you waiting to see, and what do you think the timeline will likely be?
Well, next Friday is going to be the timeline. That was announced this morning. So we'll be talking again next Friday afternoon about this very same issues, another 3 or 4 hour meeting about the same thing. So basically, I think the way I've been explaining it is we got to know the denominator and we have to know the numerator. So is it really just 6 cases? Are there more cases? Are there less cases? So that's what we need to know. There were quite a few people that have been vaccinated, 2 or 3 million, if I'm remembering the numbers correctly, that have been vaccinated with the Johnson & Johnson vaccine in the last 2 weeks. And we've seen all these cases within 2 weeks of vaccination, all 6 of the cases. So we're looking for other cases. Then the denominator, as other people have said on the panel, is, are we just looking at women under 50, or are there going to be some male cases, or are we looking at older people? And so, that gets back to the left-hand side of this graph as we're looking at it. Is it really the same rate as the general population, or are there specific risk groups that we need to exclude from getting this particular vaccine? And so that'll be the debate. And you can live stream that meeting and listen to us talk about it and listen to us vote about it next Friday.
All right. My second question has to do with the Pfizer CEO coming out yesterday and mentioning boosters. And I know that doctors on the panel have talked about Moderna looking into this possibility. I was just curious, your thoughts on this. Is this expected? What are your thoughts?
So one thing about this pandemic is that pretty much 50% of what you say is wrong when you say it within a week or two. So I could certainly be proven wrong by experience here in the next few months. But especially when we start talking about variants, yes, we may need boosters. We do have data, though, that people that have gotten the vaccines, the RNA vaccines, still have an immune response 6 months, still have antibodies, still have some of the cells that are part of the immune system still present. And so, we just don't have anybody that was vaccinated longer than 6 months ago to follow. It was basically 8 or 9 months ago when these clinical trials started. So you just can't get data any longer than that because there just isn't anybody that got the vaccine 2 or 3 years ago. So, but yeah, we should be thinking about that and looking at that. And certainly the people in the trials that volunteered to be in this trial last year deserve a big pat on the back because they're the people that we're getting information from. There were 44,000 in one trial and I think about 48 in the other, if I remember correctly, for the RNA vaccines. So.
I think that's a good point that you made. Tens of thousands versus this signal of this safety at 1 in a million. So even those numbers you wouldn't necessarily pick up in any of these vaccine trials. And also the second point is we try to preface a lot of what we say is at this point in time because we can only go with what comes in published reports and published studies and the data and follow that. So
well, and it comes out so fast.
Yes.
Dr. Hawkinson gave this to me this morning before, and I haven't even had a chance to read it yet, so it's drinking from a fire hose frequently.
For sure, and we've said over and over and over, wait 2 weeks and we'll know a little more. And unfortunately, every 2 weeks we have to say that again because there's more to learn. But we have been learning at such a rapid pace throughout the last year.
But I think it's good that the Pfizer CEO came on and said that. We've heard Dr. Fauci, other health officials really expect to have some sort of booster or some other further vaccination down the line, especially in regards to the variants, especially in regard to what it looks like now is probably the most concerning one is that South Africa variant based on the changes in the amino acids there, especially in that spike protein. But what is the best way to help stop further variants from arising or becoming more dominant as the UK variant has? Vaccination. Vaccination is going to continue to be our way out of this pandemic.
And the beautiful thing about the RNA vaccines is that you can change them relatively quickly. One of the accounts I follow on Twitter is Kizzy, PhD. Unfortunately, I can't remember her last name. Kizzy is her first name. But she was one of the inventors. She at NIAID, she got the sequence, and 2 weeks later had a working vaccine in her lab. So if we have the sequences, we can certainly make the vaccine.
All right. Are there any other reporter questions this morning? Okay. Jill, let's get to some community questions this morning then.
We have a few before we get to our follow-up Friday questions. Melissa wants to know, she is 1 in 5 of her family that she got flu back in 2019 after getting the shot. Since she got the flu, she wants to know, does that mean my COVID shot won't work? She's perceiving that her flu shot also did not work.
So there's some similarities to these stories, and again, I might be proven wrong eventually, but there's lots of data about the flu making the flu less severe. So for people in the oldest age range, they're less, I don't know how this person is, but they're less likely to get admitted to the ICU, less likely to be hospitalized, less likely to go to the ER. So it depends on your definition of working. You have less severe disease, if you get the flu shot. And then on the other end of the scale, there's a very good but very sad series from the CDC where pediatric cases of death are reduced by about 65% if you get a flu shot if you're under 17. So, so the flu vaccine works to prevent the most severe cases, even if you do get the flu. And I think we're seeing very similar data with these vaccines, only though they're a few months old. So I don't know that you can correlate one to the other, but you're going to hear this story all the time, I think.
Yeah, I agree. And I don't necessarily, the other way I look at this question is I got the flu vaccine and that gave me influenza. That doesn't happen either. Influenza vaccine is an inactivated virus. More than likely, you probably had exposure prior to that and manifested symptoms, or you had another cough and cold virus. But I think that's the important thing to remember is, these vaccines don't necessarily protect you from infection. What they do is decrease the severity of your overall disease. If you had symptoms after getting the vaccine, just imagine what your symptoms would have been like if you did not get the vaccine. They probably would have been more severe. You probably would have been more ill. And depending on your comorbidities or your age or anything like that, you may have had a higher chance of going to the hospital then and going to the ICU. So these vaccines really help decrease the spectrum of that severe disease, including hospitalization, severe disease, and of course death. So.
And if you want to stretch the analogy, pertussis vaccine works that way in kids. So all three respiratory vaccines that we can talk about off the top of our head, are similar in that regard. So.
And I think maybe one of the good things that's come out of the understanding sort of in the public of variants here is that, there are multiple strains of influenza that circulate the globe every year. And the influenza shot each year can't protect against every single one of them. Right. So it is a sort of forward-looking choice at what we think, or I say we, the vaccine manufacturers and our infectious disease experts think are very likely to be the diseases, the strains that are going to cause disease in the United States that year. And it's very possible that you had a strain that was not included in the vaccine. So you may have had a strain that was included and less severe disease. You may have had a strain that wasn't included. Neither one of those means that the vaccine didn't work for you, and it definitely doesn't mean that the COVID vaccine won't work for you.
Okay, Cindy wants to know what happened to the 6 women who developed blood clots after they got the vaccine, and how were they treated, and what were their outcomes?
So this is a very severe disease, and there was one death. Several of them went to the intensive care unit. So the treatment is not heparin, so the treatment is generally supported with anticoagulants, and I'm not going to remember the name of the drug, so I'm looking at you too.
Yeah.
The anticoagulant drug
Yeah.
that they used.
So because you had stated earlier, there is some indication that it is it's similar to what we call heparin-induced thrombocytopenia, where when you're given this drug heparin, which is a blood thinner, it actually reduces your platelets and causes you to have coagulation problems. So that is important to check for those antibodies. But also there are 2 or 3 other blood thinners on the market that we can use in the hospital or for home use that are not related to heparin, that have different mechanisms and are different molecules. So,
and that's in the health action alert from Monday, or some of those guidelines. But it is a very severe disease, and people get very ill from it.
Matt wants to know, is there evidence showing why we have breakthrough infections?
So do you want me to get started on
yeah,
that?
sure. Of course, you're our expert.
This is a hard one to be an expert on. So there are going to be some infections because nothing works 100% in medicine, and all 3 of us can attest to that. So there are going to be some people who are fully vaccinated that are going to get sick with the virus, even though they're fully vaccinated. So 95% was the number for the RNA vaccines from both trials, more or less 95%. And so the thing we're looking for now, though, is infections in vaccinated people due to variants and also their clinical outcomes. And so the reason I said that nobody's an expert on that is that it's really hard work to do, because you have to find people who've been vaccinated, and this is what the CDC excels at, find people who've been vaccinated and then sequence what they were infected with. And so I ran out of time this morning. I was going to look at the CDC's website because I thought this would probably come up. So, I mean, that kind of study, those kind of studies are ongoing.
So I think it goes back to what we were talking about is this will not protect you from infection per se. If you are exposed or you are around people and have a high enough concentration to get the virus into your respiratory tract, it will probably cause infection. What we are worried about is what is that spectrum of disease. So these vaccines will definitely cause an improved spectrum of disease. I think out of, was it maybe 3 million people, David, correct me if I'm wrong too, there were like 5,000 some breakthrough infections with 74 deaths in those. So out of all that number, imagine if those 3 million people were not vaccinated at all. So I think that's what we have to understand here is, again, continue to decrease the severity of disease and the overall rate of death.
Yeah, the CDC information that was published, I think it was last night, last night, around breakthrough infections, exactly as you mentioned, Dana, 5,000 and change infections in that known population. That as we look into the data, there are not specific patterns about location or age or demographics or even which vaccine you got. So those are good things, meaning there's not a signal that says it's related to any one of those. It's probably more related to your sort of dose of potential infection in your community, how this disease has spread from the beginning. But there were also some other interesting things there. The percentage of those that were infected that ended up in the hospital was much lower than those that ended up in the hospital in the general population. And the percentage of those that actually became infected of those vaccinated was far, far lower than the 5% that we would expect from all of the data coming out. So I think that the information around the breakthrough infections that we have, what the CDC shared from all of their hard work of diving into this, does say that in the real world circumstances, this is actually better than we would have expected. And so no real concerns about breakthrough information or breakthrough infections based on the information from yesterday.
Yeah.
And could you define breakthrough infection? Glenn is asking.
Yeah, so a pretty simple definition, right? It's anyone who has a documented infection more than 2 weeks after the completion of their vaccine series. So if it's the Pfizer or the Moderna, 2 weeks or more after their second dose, if it's the J&J vaccine, 2 weeks after the first. And this is also something that we follow in our population. I know we've shared that. When I say our population, I mean our employees. And our data would show almost exactly the same. No hospitalizations, right? A very low rate of infection in those that are completely vaccinated, and likely some impact from variants, but it's a little hard to tell. By that I mean we are sending anyone who is an employee or a patient who is a documented breakthrough infection, we are automatically sending that isolate to be sequenced. So the work that Dr. Ault mentioned that the CDC does so well, we're actively participating in that whenever we find a breakthrough infection.
We're going to go to our first. Oh, do you want to weigh in?
Well, just to amplify what you said, even though this was just published a few weeks ago, now it's getting to be old news. You know, there's a nursing home study that says pretty much what you said, and if I remember correctly, it was nursing homes in Connecticut. And then there was a healthcare study. These are both in the Morbidity and Mortality Weekly Review, which usually gets published on Friday, that says the same thing. So you know, the vaccine looks good, very good. The RNA vaccines looks very good in real life.
All right, let's get to our first follow-up question of the day. When it comes to vaccination, is the variant causing an uptick in the cases, or are people failing to get vaccinated? What's causing it?
Yes. It is both, and likely other things. And I think the really great example that I'll throw out there to start the conversation is Michigan. Right, so we've heard a lot about how cases are increasing rapidly in Michigan, how there's definitely a surge happening there. A lot of conversation about whether we should or should not send more vaccine to Michigan, for example, as an intervention. And what we know there, several things are true. Number one, Michigan is vaccinated at or above the national rate. And so this is not necessarily just a lack of people getting vaccinated in Michigan. Number two, in the age groups where vaccination is the highest, especially those over 60 and over 70, the rate of disease currently is much, much lower than in the younger age groups. So vaccines work. So it's not that there's a significantly lower number of people getting vaccinated, and it's not that the vaccines aren't working. And then from there, it's, well, what is the reason then? And it is, I am sure, related to some loosening of restrictions at a time where variants are having some impact. They're not the only cause, because the rate of variants, although it's high in Michigan, is the same as the rate of variants in the infected in several other states, and we don't see the same surge. And then a lot of other things, probably, right? Some hesitation among groups who for vaccination among groups who are out and about a lot. And also a fairly rapid and somewhat alarming increase in infections in those who are younger, children especially. So put those things together, and I think that's the recipe for Michigan. And so the answer to that question is yes, and probably many other variables. And I don't know, I'm sure that others have thoughts too, but that's a great tangible example of what we've learned from someplace that's seeing a lot of spread.
Yeah, I mean, I wouldn't say it's the vaccination, the way that was worded. We continue to have more published studies. In the last 2 weeks, there were laboratory studies published regarding the mRNA vaccines and showing that there is still a high or robust amount of immunity even to those variants, especially the UK variant. A little bit less with that South African variant, but we know that is spread less prevalent in the United States. I think really what it is it continues to be a behavioral thing. Just as you mentioned, David, about lessening the restrictions, it's COVID weariness. It's people wanting to get back out there. It's nice out, wanting to gather. We all want to do that, but this is the behaviors. These are the behaviors that cause the spread of the disease. In addition, it is that behavior of vaccine hesitancy, because we know that the vaccines do work to protect against the spread or the disease, the spectrum of disease, but also, as we are finding more information out, more than likely the spread as well, especially if you do get infected after having the vaccine.
Is the Moderna vaccine harder on the body than Pfizer? I've heard people who take Moderna have more reactions and symptoms post-second dose.
Harder is a hard word. So they're both reactogenic. I mean, I was thinking when you were talking about flu doesn't give you flu vaccine, I happened to get exposed to COVID the same day I got my second COVID vaccine. So when I had a fever, right away, it was like, which do I have? A side effect of the vaccine, or do I have COVID? So, but about 3/4 of people are going to have some side effect from this vaccine, including fevers and sore arms and lymphadenopathy, swollen lymph nodes, and that type of thing. So I think those numbers are pretty equal with both vaccines. I mean, I would expect it if I was going to get either of those vaccines. So.
Yeah, I agree.
Okay, we have spent zero time with our grandchildren indoors since this pandemic began. We are now fully vaccinated. Can the grandchildren come inside to play without masks?
Well,
CDC guidance.
so I guess it depends answer. If the grandchildren are all from the same household, right? If you've got 3 grandchildren and they all live in the same house, then technically that would meet the requirements or sort of the recommendations, I should say, from the CDC. If they're from 3 or 4 different households, that would be outside of what's recommended. It's hard. Don't want to say they can't or shouldn't, but definitely the CDC recommendations come into play in how we answer this.
I think that you, as the vulnerable population, grandparents, if you're fully vaccinated, that will certainly help. But as you said, per CDC recommendations, you are able to meet with one other household that is not fully vaccinated with your mask off in doing that. So I think, again, it goes back to also, so that is the black and white words on the paper, the guidance. Also understand what risks you're taking and be the judge for yourself on do you think you can meet with them and be safe and go from there.
I would also maybe add a caveat, what's going on in the community where the grandchildren live. So if it's a hot spot where they have lots of places in school, lots of outbreaks in schools and lots of teachers in quarantine, you might want to put it off for a little while.
And that's a great reminder that this is all about risk mitigation. So maybe those grandchildren are homeschooled and they don't have interaction with other people and they've got a very small closed bubble, in which case the risk would be low and it might be the absolute right thing to do to have some time or to be able to spend some time with them. So again, lots of it depends in there.
But I think it's important, if you're fully vaccinated, you are probably going to be optimally protected from that, again, that wide spectrum of disease.
How long are vaccines effective? 6 months? A year? How long am I protected?
Dr. Ault, you sort of addressed this in the data, from the data perspective.
Right. So what we know now is 6 months. And the main reason we know it's 6 months is that we have some people who've been followed that were vaccinated in the middle of last year who are still protected. So we don't have data about 2 years or 4 years or 10 years like we do for other vaccines, because these vaccines weren't around more than a year ago. So yeah, six months is where we are now, but we may change that optimistically going forward based on what we know about antibodies and lymphocytes that respond to this vaccine.
All right. Both our 7 and 10-year-old had COVID-19 in the fall. Do they have immunity against the old and or new variants? What should our plan be to keep them safe until they can be vaccinated?
Yeah, some of the earliest recently published data would suggest that, number one, if you had mild symptoms or no symptoms at all, based on antibody testing, because that's what they're looking at, your antibody titers probably are not as high as somebody who had more severe disease. Also, back in the fall was probably more closer to the Wuhan strain or the D614G, one of those variants that was circulating, rather than the variant that has become more common in the United States now, the B117, the UK variant. So that immunity based on looking at neutralizing antibody titers probably is not as high as if you would have gotten an mRNA vaccine. So, they probably don't have the greatest immunity, and it's certainly have that risk of getting reinfected with any one of these new circulating variants.
And as far as what your plan should be to keep them safe, there are two broad answers. Number one, start with get your vaccine and have anyone who is around them get their vaccine. Because if you are vaccinated, you've reduced the risk of transmitting it to your children who are not yet in a population where there's a vaccine that has approval. Secondly, nothing has changed with pillars of infection prevention that we have shared now for 14 months or more. Of course, that doesn't mean that you can keep them inside the house and not have contact with others, and so we know that includes masking, right, as part of that plan. And I have a 4-year-old and a 12-year-old, and so I know that both at times would rather do anything but wear their mask, but I also know that even the 4-year-old is capable of doing it and keeping himself safe when we need to. So I would suggest you do those things, right? 2 broad paths to do everything you can to mitigate their risk.
Can you elaborate on the CDC guidance regarding surface transmission?
Dana?
Yeah, I mean, it's just the broad concept of, initially we were taking a lot of precautions about fomites or inanimate objects being able to spread. We still know they can. We know the virus can live on surfaces. But as time goes on, after hours to days, the concentration of those viruses that can still replicate and infect you is probably less. We know that overall, the main way that this virus is transmitted is through respiratory droplets through the air. So, while inanimate objects or fomites may pose a risk, it is certainly much less risk than being in an enclosed space with somebody who has the disease. So I think, again, it is still warranted to continue to do adequate hand hygiene. Also, try to avoid touching your hands to your eyes, your nose, your mouth, because you potentially could get it, but it is certainly much less than being in an enclosed space with somebody.
Can you drink alcohol after receiving a COVID-19 vaccination? Does alcohol interfere with building my immunity? I would ask, is there any food or drink that interferes with building immunity? Certainly we would not encourage anybody to go binge alcohol if you're taking the recommended 1 or 2 glasses of alcohol or wine a night. That should be fine. So I think overall, again, the immunity is going to be building over the next few weeks. So doing it, right after you get the COVID vaccine that evening or maybe a couple days later is not going to significantly affect building that robust immunity now.
That sort of concept of a single event or a couple, right? 2 doses of Tylenol, 4 hours after and 12 hours after a vaccine are not likely to have a huge impact on how you develop immunity. This, I think, is in the similar vein. A single day or 2 days in that 2-week period where your body is sort of manufacturing all the immunity that it's going to is probably not likely to have a significant impact.
I remember you guys told me to drink a lot of water and I'd feel better. And it's true. It does. It does help. If we are completely vaccinated, do we need to double mask?
Dana, your favorite double masking topic?
Yeah. Again, there is some CDC guidance for double masking, but if you look at that guidance, the majority of that is really focused on making sure that mask fits tight, whether it's a single mask that is a surgical mask or one of the cotton masks. And again, the study that they based a lot of that guidance on was really a specific study for double masking, and that was a cotton mask over a surgical mask. It wasn't 2 surgical masks. It wasn't 2 cotton masks. Certainly was not 2 N95 masks. So I don't think you really need to change anything you're doing if you're doing appropriate masking now, and that is making sure that the fit is good. If you are continuing to wear a double mask, that's fine. But the guidance still remains you do need to mask in those public situations or in those workplace situations, even if you're fully vaccinated, except for when we talked about when you don't have to mask.
I have 2 grandchildren with severe health issues. One has an artificial heart valve and the other is a cancer survivor. The family is opting not to be vaccinated. What are your thoughts on this?
Well, Dr. Ault, obstetricians work long and hard to bring healthy babies into the world and make sure that children and parents are healthy and safe. As kids grow, that desire doesn't go away. Do you want to maybe start here?
Well, there isn't a vaccine for children yet. So it doesn't say how old these children are, but we'd expect adolescents to be vaccinated with one of the RNA vaccines sometime in the future. When I started getting messages on Monday night, I thought maybe that's what we were going to be talking about in an emergency ACIP meeting. But I'd expect you're going to hear about that now soon, and you're going to hear data from those clinical trials. And the data from the clinical trials that you can get by going to the New England Journal of Medicine website or the FDA website or the CDC website, is very reassuring. And so I assume the data is going to be the same for the adolescents. And so if you're the grandmother, you're going to have data to influence decisions. So I guess I'm not that familiar about whether those particular conditions put children at an increased risk. You would think that it would. So certainly for adults with cancer, especially if they're being actively treated, COVID is not a good thing. So it's hard for us to give advice, I think, about family dynamics. But, we can give advice about where to find data.
Yeah.
So,
I think my thoughts on this as a medical provider is I would recommend against that. I would recommend getting the vaccine individually for you and your family, especially I know I would not want my children getting COVID and then having that risk of getting that multi-system inflammatory disease either, especially if they had health problems. So that's individually as you and your family. For the community and, globally, I think it's very important to get vaccines, again, to help reduce the spread of disease, help reduce the chance that other variants may arise as well.
It's a little hard to tell from the question if the family is not wanting these children to be vaccinated when it's time, or if the other family members are not willing to be vaccinated now. And if that is the case, if it's family members, the parents and other family are opting not to be vaccinated, I would reiterate the sort of plea that the best thing you can do until your children can be vaccinated is to get vaccinated yourself. Anyone who will interact with them who can get vaccinated now should be, without a doubt, because that's a huge step in preventing transmission to those children who are probably at some degree of increased risk, especially if, say, the cancer survivor was of a lymphoma or leukemia, where we know there remains an increased risk of immune or infection causing problems.
We have this last question, but we need to clarify on another one. So the last question we have, another grandma. I'm a grandmother who is fully vaccinated and planning a trip with adult grandchildren who are not. Is it safe to be around the family without a mask?
Well, I think this is similar to the first grandmother question.
Yeah.
It sort of depends. Maybe the different part here, the depends, is actually a little bit bigger. So, yes, it depends on whether it's one household or multiple for those grandchildren. Yes, it depends on where those grandchildren are from and what the disease transmission looks like in their community. But it also depends on where you're going in this case and what you're planning on doing. And so safe is a relative term. We know that you can mitigate your risk or do different things. And I don't know, Dr. Ault, if you've been traveling, but I know Dana and I have traveled during the last year and been able to, even with our kids, been able to figure out ways to reduce the risk for them. So it's not necessarily that it's unsafe to do, but you very well might be considering a mask in almost every circumstance when you're with them and when you're out and about. Now, Dana, do you want to?
Yeah, no,
Take it
I
from
think
there?
that's exactly right. It continues to get to what is the risk that you are willing to take, and how can you mitigate risk as much as possible. And I think you kind of hit on all those points. Yeah, individually, you with being fully vaccinated will be, again, protected from that large spectrum of disease, especially hospitalization, severe disease, and death. So.
I'm trying to imagine my mother or my mother-in-law in this
Mm.
situation. I think they would say those kids should be vaccinated. So, I think that would be the,
Yeah.
because I don't know that there would be any barriers to
don't
getting
know.
vaccinated
Yeah.
in Missouri or Kansas,
No.
assuming that's where our questions are coming
No
from.
barriers
So,
yet. Yeah.
Yeah,
And,
so.
and I suspect we have a vaccine appointment or two open.
We do. As most vaccination sites across the metro, there are vaccine appointments or slots available today, throughout the weekend, and next week. If you haven't yet, you can sign up through MyChart if you're a patient here. But we also have the ability for those who don't have a MyChart account to do so electronically on our website, kansashealthsystem.com/vaccine. Or if you'd rather call and schedule an appointment, 913-588-1227. We'll hit that again, I'm sure, one more time here as we wrap up. But yes, if you need the opportunity to get a vaccine, we definitely can help. Give us a call.
And we have lots more questions, but I'm only going to give you one more, and it's from Catherine, who, because we're running out of time, she wants to know on the guidance, one household at a time, is it one household at a time, or choose one household and that's the only household that you can interact with?
So the CDC guidance,
Yeah.
my interpretation is when you gather as a group, if you are vaccinated, you can gather in that moment with people from one household who are not vaccinated. And that household should be not fully vaccinated, meaning if the adults are, but there are children in that household, that counts as not vaccinated.
Yeah.
I don't read it as pick one and limit your bubble.
Right. Now, it gets hard, too, because we knew on Easter people wanted to go from household to household. So, that makes a difference as well. There's no strict guidance on that. Again, it's this concept of identifying who is at risk. Is everybody in your house fully vaccinated? And that includes, children, too, but obviously children can't get vaccinated. So it is really still kind of a gray area. But just to the fact that David was talking about as far as identifying that one household, and it doesn't have to be just that strict one household and that's it. But it does get into a gray area, especially if you're doing celebrations or, like I said, holidays where people are wanting to go from household to household. Again, that will just increase your risk of being exposed to the virus.
All right. Well, Monday marks the start of National Volunteer Week, and we've two guests who help us with our COVID-19 vaccine clinics. Vanessa Goldsberry is our Volunteer Services Director, and Elaine Struve, who began volunteering to help pay it forward and now helps with our clinics, will join us. More on that next week, but first, yesterday there was conversation about prom and graduation safety during COVID-19, and some of you asked to see prom pics from Dr. Hawkinson and Dr. Stites. I think we maybe dug one up here for you, so Dana,
Sorry,
tell us
Karen.
a little bit about that picture and who you're with.
It was senior prom. I mean, I don't know. We actually got to go to senior prom and not be masked and have the dance and have a good time. That's Karen Zaguna. She is actually a frontline worker and a nurse, so please thank her for being a hero and doing that. But yeah, long time ago. Actually, it was only about 10 years ago. So
The haircut might be similar,
I mean, yeah, it looks good. It looks good.
All right.
I don't think there. Yeah, we had fun dancing and dinner. Everybody does dinner and probably pictures and.
Did you have a limo?
I don't remember. Probably
It was
not.
less than 10
Probably
years
not.
ago.
I know.
All right. Well, as we wrap up today on that lighter note, Dr. Ault, any final thoughts?
Well, stay tuned. We're going to have more to talk about next Friday. So if we get together the week after that, we'll talk about all these issues once again with new data.
Very good.
I just want to thank Dr. Ault for coming in. It's nice to have an expert here in the health system and in the region, so enlighten us with some of this information. Again, everybody continue to get vaccinated. That is my final thought. That is our way out of the pandemic. We know that the vaccines can even help us against the circulating variants that we know about. So continue to do that. Keep your individual family safe. Keep your bubble safe. And then that bleeds out into the community, our nation, and the rest of the world as well. So,
I have a handful this morning. Number one, we'll try and dig up a Dr. Stites prom picture, but that might be a little harder. We'll see.
We'll call his mom.
We'll call his mom. There you go. Secondly, I too would offer my personal thanks to Dr. Ault, not only for sharing information with us this morning, but for his expertise and willingness to commit time and effort at the national level to make sure that that we know that everything that can be done around safety and oversight of this process is being done. It is probably a thankless job at this point in time. I think, we all believe here strongly in our commitment to improving the health of our community. And it is through information like we share here and through expertise like we have around the table today that we do that. And we do it very, very proudly, but also knowing that it is a big part of why we're here. And so we'll keep doing that regardless of the issue. But personally, I thank all of our team, Dana included, right, Dr. Stites, and Jill and all of the team here in the studio who help us get that message out. Those are very important parts of doing what we do here every day. And then finally, on the vaccine front, we know without a doubt that we're at the point where those who are maybe a little bit hesitant or questioning whether they're going to get the vaccine or get it now are the people that we really need to work on getting vaccinated at this point right now. And so if you have questions or concerns, if you're on the fence still for any reason, please do reach out to anyone you think can help you with the information needed or the maybe reinforcement or even just a little bit of a, it'll be okay sort of guidance, whether that be someone here at our health system or your own primary care provider, someone you have a trusting relationship with. We aren't actually anywhere near the 80% that we think we need to really see the population benefit of vaccination. And although 30% or approaching a third is great, and we do believe that we could be at a point where the majority of the adult population is vaccinated by maybe mid or late June. That won't happen unless those who are sort of on the fence do figure out ways to get their questions answered, their concerns addressed, even if they're not completely alleviated. So if you need those things, please reach out to the people who can help you. If you're looking for a place to get vaccinated, as I mentioned, we have the ability to do that as well. You can sign up via MyChart. You can go to the website, again, kansashealthsystem.com/vaccine. Or you can pick up the phone and give us a call, 913-588-1227. And on that note, have a great weekend. Be safe out there. We'll see you next week.